The National Coalition for Cancer Survivorship advocates for quality cancer care for everyone touched by cancer. Founded by and for cancer survivors, NCCS defines someone as a cancer survivor from the time of diagnosis and represents the millions of Americans who share a common experience, living with, through, and beyond a cancer diagnosis. In Cancer Convos, NCCS talks with survivors, advocates, caregivers, providers, and health policy experts about survivorship advocacy and public policy. For more information about NCCS, visit our website at canceradvocacy.org. And now, CEO of the National Coalition for Cancer Survivorship, Shelley Foldnasso.
I am excited to welcome our guest, Dr. Don Dizon, a medical oncologist who specializes in women's cancers. He's a professor of medicine at Brown University, director of medical oncology at Rhode Island Hospital, and director of women's cancers at Lifespan Cancer Institute. He's a prolific writer, including blog posts for ASCO Connection, and he is chronicling his experience on the front lines of oncology during the COVID-19 pandemic in a series for Medscape entitled COVID-19 Diary of an Oncologist. Thank you so much for joining us, Don. We really appreciate you being here.
Honored to do it.
First, I want to talk about your Medscape series. It's incredibly compelling reading, and I think it's important both for healthcare providers and patients and advocates to read. You explore such a wide range of topics, including patient concerns, practice issues, clinical trials, psychosocial needs. How did this come about, and what topics are you exploring, and what feedback have you received?
Right. It's been an interesting opportunity. I've been a columnist for Medscape only for the last 6 months, and I took a challenge with them because they had asked me to do something different than what I've been doing thus far. Their ask for me was to try to write on topics that have relevance outside of just oncology, things that docs across the world, no matter what their specialty, might also identify with. And I really like that challenge. And then COVID-19 hit the United States, and they reached out to me and asked if I'd be interested in sort of doing a daily chronicle of what it's like to be practicing in the midst of COVID-19, not so much from the acute aspects of urgent or intensive care, but the perspectives of being a cancer specialist when the eyes of the world and all of the fear and all of the acute illnesses seem to revolve around discussions and concerns regarding COVID-19. And I thought it was a really interesting opportunities to reflect on this time. And so I took them up on it.
Well, I want to read a couple of quotes from 2 of your recent diary posts that I think really hit home what cancer patients are feeling. So here's one. Cancer never got the COVID-19 memo. It wasn't following any stay-at-home orders. It was still disrupting people's lives as ever. And my role in helping them make sense of this life-changing diagnosis wasn't stopping either. And the other quote is, people are continuing to face new cancer diagnoses every day. Those with cancer require frequent visits and follow-up. People with cancer cannot be told that oncology programs are closed until further notice.
Right.
I love these 2 quotes because you really articulate with compassion and candor the challenges that cancer patients are facing, dealing with both this pandemic and a devastating cancer diagnosis. You know, cancer doesn't stop, and the needs of cancer patients for your services and really for our advocacy as well continues. And I appreciate you using this diary series to articulate that. Can you talk a little bit more about what you're hearing from cancer patients about their fears and their anxieties around dealing with cancer during this time?
Sure. I mean, there's so much out there. If you just go on social media, and, I have a presence on all of them, but specifically on Facebook and on Twitter, those advocates and people with cancer who are vocal on the social media space have been very expressive about these concerns of access to care, even as every cancer center has moved towards continuing their programs while reducing the risk of COVID-19 by moving to telehealth very quickly. It didn't really address some of their concerns regarding therapeutic access, specifically around the issues of clinical trials. When you're faced with an institution, and I'll just pick Boston for right now because we're in the midst of the surge, where, my former institution at Massachusetts General Hospital is really facing the pandemic firsthand, and it's an all hands on deck situation for the clinicians. And where you're seeing people being admitted with COVID-19 as the predominant reason they're going not only into the hospital, but the intensive care unit, that diversion of resources can be exceptionally scary for people with cancer because
Mhm.
all of a sudden these critical cancer programs are either having to halt normal operations in their cancer centers, normal operations that would see clinical trials enroll, not only because A, their physicians are being pulled to help cover critical services at a critical time, but we're talking about a situation where we're reducing the risk with folks who actually work in those centers as well, and everyone's working remotely. So
Mhm.
you think about what it takes for people to actually get treatment in this country. You don't just walk into a cancer center, walk into the infusion unit and say, I'm ready. There are multiple points of contact for anyone with cancer and their institutions. And when those institutions have to divert energy and efforts, one of the things that goes is the outpatient clinical programs. And that's where oncology sits now because we've been so successful in moving cancer care into the outpatient setting. Very few people are actually having to go into the hospital for treatment. So I think faced with this sort of landscape where centers had really reduced their availabilities towards treatment, either on trial or standards of care, I was actually hearing quite a bit from people who are having their appointments delayed, having starts of treatment delayed, having ongoing therapy delayed, or being told that clinical trials were on pause for right now. And it did make it seem like there was only enough attention nationally, regionally, locally towards meeting that pandemic. And unfortunately, I don't think that message was the one we wanted people to hear from the perspective of a clinician. We never wanted people to hear that their cancers had to take a backseat to COVID-19. That was never the case. And here in Providence, Rhode Island, leadership at the Cancer Institute, we are doing everything in our power to continue normal operations in the infusion units. So we haven't had to, and I'm going to put it that way specific, we have not had to stop our clinical trials program. We are continuing to put trials through so that we can open them. We are still treating people on clinical trials. We're still offering people clinical trials. And even for me as an investigator, running my own studies, I've worked with the FDA and I worked with local institutions because I do have patients who travel to Providence for the therapy about alternative ways to get people study drug that doesn't allow them to travel. And it's been really heartwarming to see not only has the FDA provided really important guidance, but institutions where my patients usually would go for care, which is not inside the area of Rhode Island at all, are willing to partner with me to make sure that patients stay on track on trials.
That's great because I know that there's a lot of
Mhm.
concern on the part of advocates and patients about disruptions to clinical trials. So it's good to hear that you're able to keep them going in your center, at least. I know that that's not the case everywhere. And you did write recently about, I would say, Herculean. You might not describe it that way because you're more modest, but the effort you went through to make sure that a patient who lives in South Dakota could remain on the trial without having to travel to Rhode Island for treatment. Can you tell us a little bit about that?
Sure. And of course, I will preface that by saying that, patient anonymity is important. So the details of that particular case were obviously hidden. But yes, I did have patients who are enrolled in a very rare cancer clinical trial. We're testing immunotherapy for a cancer called clear cell. And this trial has attracted patients from all over the country, even outside the country. I did have a few folks from Canada come in to get more information about the trial. And when COVID-19 hit, the biggest concern was, do I ask them to pause until the pandemic is over, which we didn't know when was going to happen? Or do I ask them to come to Rhode Island, where we were actually asking visitors to quarantine for 14 days? So knowing that if they traveled here, there's a possibility they wouldn't be allowed to leave for 14 days. And the third alternative was, could I provide them the study drug locally and still keep them on trial? And in normal operating procedures, that is not an option available to any of us. But the FDA put out guidance for clinical trialists that allowed for deviations to protocol. It allowed us to do study follow-ups virtually. It allowed us to, reduce the amount of visits that a study participant or a study volunteer was going to have to make to the cancer center. If I was running blood work studies for a drug, it allowed us to deviate from those schedules, even if the study was going to be hindered in some way, as long as the scientific merit of the study, the primary objectives of the study were not adversely being impacted, and as long as patients were safe, then they were going to allow us a lot of flexibility. So in my case, I had to reach out to the FDA and ask them for their guidance in getting study drug, which was being shipped to Providence, getting that study drug to patients where they lived, rather than asking them to travel to Providence, Rhode Island. And they provided that specific guidance. I had it in writing that we were allowed to ship study drug directly to patients. They gave us some provisions of that. It took a lot of calls to local physicians who, by the way, at the first request were all in. They were just like, absolutely, tell me what I need to do. They provided me contacts with their institutions. And those were probably the most sensitive parts of this whole thing, to receive a call from an outside investigator saying, I need you to provide study drug for this patient, but I'm not asking you to open the clinical trial. That doesn't make sense at all. But this is an extraordinary moment in time, and it was an extraordinary circumstance. And after speaking with leadership and it going up the chain, and not only one, but a couple of institutions, both of them were on board to do what was right for our patients.
Well, that's incredible. I think that's so important for patients to know that there are physicians out there who will really go the extra mile to make sure that they can stay on clinical trials and not have to have that kind of disruption in their care during this time. You also wrote about concerns your patients have for their safety when they come in for treatment and how you're working to protect them from infection. Can you tell me a little bit more about what you're hearing from patients and what you all are doing to mitigate the risk?
Well, I think the most important thing is that patients are very understanding. If there was ever a way to phrase the term partners in care, this is it. We've received very little pushback about what we're asking people coming into the infusion center to go through. We're asking them to, submit to queries about whether they've been sick or not. We're asking them to wear a mask. We're asking them to come alone. And for our patients who are being admitted to hospitals, their loved ones are not allowed in the hospital right now. There's no exceptions. So I think that's pretty remarkable because, some of the treatments that we administer go for 6 hours at a time. And, families have been sitting in their cars waiting for their loved ones to get done with treatments. And I think that's been pretty incredible. We haven't been, I think like the rest of the country, testing is a big issue here in Rhode Island, even though we're, on a per capita basis, Rhode Island is doing exceptionally well in terms of testing. But we're still looking for screening criteria for those tests. So unless someone has symptoms, they're not being tested. And I think that has to change at some point. But we are not testing everyone who works at the Cancer Institute. So I have never been tested for COVID. I'd love to be able to get tested for COVID, but I haven't. None of our infusion staff, none of our clinical staff have been tested. And none of our patients have yet to be tested unless they're going into the hospital. And I think, there's a big leap of faith in that, right? So if you're an outpatient and you are, say you have heart disease, you're a man and you're getting chemotherapy, it looks like having cardiovascular disease, it puts you at severe risk of having a serious COVID-19 infection and even dying of the disease. I always wondered, do they wonder if they're safe coming into the infusion area? And there's no way for us to do those guarantees. So my last column was about a patient who basically said, I want proof everyone's fine. I want to see a negative test. And that was an interesting first experience that I had in all of this, where a patient was so worried, but still needed to start treatment for curative intent and really was looking for reassurance that we could not provide her. I mean, that it is just not ethical to ask to see my medical records or anyone else's medical records. And that's not an expectation that patients have or should have But do I understand the fear? Absolutely.
Right. I read that piece and you raised the question of how often healthcare providers should be tested, even though you don't have the obligation to provide that information to patients. But you said, a negative test a week ago doesn't necessarily mean someone's negative today. But you also said it helped you see really the depth of anxiety that your patients are facing as they come into, even if it's outpatient therapy, in having to come into a medical institution during this time when everybody's being told to stay at home produces a huge amount of anxiety for people.
Oh my gosh, a huge amount of anxiety. I mean, I have folks who it's crippling, and I think there's a lot of controversy out there of whether or not the fear that comes with COVID-19 is so out of proportion to the risk. And, I understand how people say, there's been 50,000 deaths. That's far less than have died of the flu. But remember, it's like that's in the flu, there's a vaccine, and we're talking about deaths from the flu in a year. This has been in 2 months. And I think that cannot go without being stressed that we've seen 50,000 deaths since the end of February, you know? And while I do agree that most of us will be asymptomatic, it's not about us. It's about who could catch this and become very ill from us, and I think that's where the fear is. But at the same time, just like cancer centers are like ours, we're committed to staying open. We need people to hear your condition, whatever disease that you need treated, that is not any less important than COVID-19.
I've been reading that there's a lot of concern that people are not coming to the hospital for things they should because they're so afraid of the risk of being infected, but also the overloaded healthcare system that they're not coming in for other things. And maybe cancer is not in that category, but people with chest pains maybe not seeking treatment, and that we're going to have a whole nother layer of people affected by this because of their other conditions.
Right. I mean, even so far as in the state of Massachusetts, Governor Baker, they've had to put on a public service announcement saying we are open for you, that there is hospital capacity. If you're having a heart attack, don't die at home. Come seek help. And, I saw the latest graphs that came out of the Financial Times in the UK looking at all cause mortality since COVID-19. And across the world, people are dying at rates that are exceptionally higher compared to last year. And it just shows that there is significant, to use a phrase that, that's not applied into this space. There's a lot of collateral damage that's going on due to COVID-19. And we need to figure out how much of that collateral damage can we prevent.
So I want to ask about, we did a webinar a couple of weeks ago with Dr. Otis Brawley, and he talked a lot about the change in the risk-benefit calculation or assessment for people making decisions about whether to have adjuvant chemotherapy. And that, for some people, that is no longer more beneficial than the risk of COVID. And I wanted to ask you about that, how you're addressing that, and then how do you deal with the additional fee, the increased risk of recurrence for somebody who forgoes adjuvant chemotherapy and basically doesn't have that long-term benefit of potentially reducing the chance of recurrence.
Right. I mean, I think that's the delicate balance that really it underscores this whole idea of shared decision making, right? I mean, it's just so much more important to share that. I never want to be in a position to tell someone what they should do, but it is my job to not only put the risks and benefits of any treatment in perspective, but now through the lens of a possible COVID-19 infection, which no one can really speak towards individual risk for, right? I've had scenarios where it's been a young woman coming in with breast cancer, for example, knowing that the ORs, there's one available, and the rest are slated to turn into ICUs from COVID-19 should the surge hit Rhode Island. So I know already that surgical capacity is limited and that there's a difference between someone coming in requiring surgery for a burst appendix and someone who can have a breast surgery in, say, 3 weeks as a scheduled procedure. That's what they mean by elective procedures, by the way. It's not I need a nose job tomorrow as an elective. That's not it. It's a surgery that can be scheduled later. That's what they mean by elective procedures. Where our abilities to have elective procedures limited, we're actually, using more and more primary therapy to keep the disease in check, if not shrink it down before surgery can really resume in earnest. But I've also chatted with someone in their 80s around a diagnosis of a new sarcoma, and whether, even though resection happened, early February, does it really make sense for you to have chemotherapy now versus just surveillance? The risks and benefits, are far more leading to, in my opinion, towards risk, especially for someone who had surgery and has no evidence of disease right now. So I would, I've had to sort of give that opinion about the risks of this treatment anyway, outside of COVID-19, and why it may not make sense. And then just say, in the context of COVID-19, I have great concerns about doing that. But, with all these discussions I'm having with my own patients around whether or not we should and can delay, the paramount issue is I can't even suggest it if I think I'm going to adversely impact their risk of either progression or recurrence. So if I'm looking at a woman and saying, if we give you chemotherapy, I can cure you, it makes no sense to me to then say, we can start this in 3 months. Because to your point, Shelley, you're looking at a window of opportunity for disease control that's probably, slowly closing with waiting. And the standard for me, after particularly gynecologic malignancies, start within 6 weeks. I have no idea if I can even say I'm giving you intent with cure in mind if I start you 4 months later.
Thank you. So I'm just going to interject here. I got kicked out for a second, so I did not hear all of your answers, so I can't really comment on it. But thank you. I'm glad that you were still talking when I got back on. My computer just completely died. So anyway, I'm just going to go on to the next question without any comment on that because I didn't hear everything you said. But thank you for answering that question.
Okay.
You wrote about telehealth, which has really exploded with the pandemic, keeping people at home. And there are obviously pluses and minuses to telehealth. What can cancer patients and survivors do to get the most out of a telehealth visit? And how do you foresee the use of telehealth in cancer care post-pandemic? Assuming we get to a post-pandemic time of our lives. I know that's a little bit far out right now, but I know that, I think that what's happening now is going to impact, what happens later.
I think it's very interesting regarding telehealth. I wrote about my concerns with it. I'm a very tactile person. I like to hug people, at least shake their hand. If it's a very difficult discussion, I like to sit closer to people and even put my hand on their shoulder if I feel like they're struggling. So it's been very difficult for me to move to telehealth and really show empathy. I think it's possible, especially with eye contact. So where do I think this is going to go? I think it's going to be an interesting tool for us, especially for folks who don't live near the cancer center. I mean, this will really help, I believe, with outreach. So, we've always talked, even before the pandemic, about, is there a way for us to make this easier, especially for people who are done with treatments? If they're just in follow-up, is there a way for us to come to them rather than them come to us? So I think logistically, it's just we've accelerated the work that's required to make this a part of our standard armamentarium so that we can offer this to our patients, especially those who are seeing us on a yearly basis, who are really resuming some semblance of normalcy. There's no reason anymore for them to come to the cancer center should they choose an alternative, because there is now one here. Beyond that, I still think it's so important for people facing a new diagnosis, for people reviewing a CAT scan, for people facing a recurrence, and particularly for people nearing the end of life, to have all of those visits in person. There's just so much that needs to happen. And, for me personally, and probably very selfishly, it's important for me to be able to provide some closure, especially if someone is nearing the end of life, to be able to say to someone, I appreciate that I was in your life and that I got to meet you and your family. I think those are very healing words just for the oncologist as well. I think it's going to help. I don't think it's going to replace anything. I think for our patients who are on the other end of this, look at it as an opportunity to invite whoever you need to be in that room with you, because maybe it's the daughter who lives in California who's never been able to make a visit. Telehealth can now make it possible for you to gather the people that are important to you to be a part of that visit. I think it's also important not to feel rushed. I think that this is a time where you might feel less inhibited by asking for clarifications, for example. But it's also a time where you should never feel like your time isn't as valuable as ours. We always say, the docs speak for 5 minutes and they're out the door. But for most docs, it feels like we were in that room for longer. Now we're both on the same page because we have to time the visits, so you can actually see how long we spend with you and make sure that that's time that you believe is well spent because it's time that, again, this is a real visit and that time is important.
That's really helpful advice to make the visits useful. And I think you made a really good, important distinctions between the types of visits that really lend themselves to telehealth and the ones that don't. I don't think that you're being selfish and wanting to have that closure and the end of life kinds of conversations in person, because I think that's just really a human need, but on both the provider and the patient. And so I think that you did a great job of articulating kind of where it works and where it doesn't, and then also to how to help be prepared. I think it is a really big benefit for people who don't live where they were treated, for people who are in survivorship care and the follow-up care where they may not need to take off work to come in and address the questions that they have that can be done over telehealth. And also, I think you're right that it's a huge benefit to be able to bring in other family members who might not have been able to be part of the discussion. So those are some really important positives of telehealth.
Yeah, 1000%. I agree.
So we've talked a lot about people who are in treatment, but we also hear, from survivors who have completed treatment, incredible anxiety about their risk and their ability to sort of, manage that risk. So what is your best advice to cancer survivors who've completed treatment but still feel extremely vulnerable?
Right. I think that's a really important aspect as well, because we do know in the first, several months out to a year after completions of treatment, that there's a real fear of relapse that if it happens. There is that sense of vulnerability because all of a sudden you're having to handle the world by yourself. I think acknowledging, and it's really up to us to help introduce the concept. There's so many people who feel that they're embarrassed by how vulnerable they feel. And I think the isolation of physical distancing can add to that and almost introduce loneliness to the experience. I think it's really important for people to know that social distancing is about physical presence and keeping distance from people physically. There's nothing that's preventing any of us from reaching out to others socially. So, I think social interactions remain important even the time of stay at home. And I think reaching out to your treatment team and letting them know that, yeah, you know what, I'm finding this hard is really the first step. What I'm trying to do is to reinforce the topic that the first year outside of cancer treatment is not one where people are really celebrating their understanding or they can no longer ignore the limitations that they have due to their cancer or their treatments, and they're confronting. So in this drive to be, rediscover one's quote normal pre-cancer life, the dawning that it's never coming back, the dawning that there's this new sense of normalcy is a process rather than instantaneous. And unless someone explains that, I think they're going to lead to a lot of anxiety and perhaps disappointment, self disappointment, because they're not reaching what these perceived milestones might look like. So, as long as people understand that there is a normal process of grieving as well as recovery at the end of treatment and that they are not alone, those are the first steps. But certainly reaching out to your cancer center, even if it is by a Zoom call or by a phone call, is more important than trying to deal with it alone.
That we hear from cancer patients all the time that the first year after treatment is harder than the treatment itself. So I think what you said really resonates because people have this, expectation that they're done with treatment. Sometimes there's a bell ringing or a party and that things are going to be normal and they're not. And then add on top of that this pandemic that everyone's dealing with. I think you're right that reaching out is really important. I know we're trying to provide opportunities for patients and advocates to network with each other and really reduce some of that isolation that they're feeling right now. So I want to
1000%, I agree.
well, I want to change topics for a moment. And what our listeners may not know about you is that you are a TikTok phenom using music and your dance moves
I don't know about that.
to get across public health messages. So, how did you decide to use TikTok?
I don't remember what I was looking at Twitter, but something came up which I thought was really entertaining. And the tweet was saying, there are things you can learn on TikTok. And I had no idea what that was. This was probably, 4 or 6 months ago. So I downloaded it. And I got to say, what first struck me about it was a really, really entertaining platform. And they're so short. So it definitely speaks towards these type A personalities like myself who have, shortened amount of times. We tend to see life in terms of a checklist of things we need to do. It was a great way for me to remove myself from my checklist and just do something fun for a little bit. So I never ever got lost in it. So it's not like I opened TikTok and 7 hours later I've just wasted so much time. I could do things in little spurts, but it was just a lot of fun to see normal people, no celebrities, some of them very TikTok famous, never would have heard of them otherwise, but just seeing how creative people were. And that just sort of got me thinking about how it could be useful outside of TikTok. We know very well that, posts and tweets that are more visually attractive, are linked to video or just have, multimedia components to them are more likely to engage. So I felt this was an exceptional platform just to create little snippets and then use them elsewhere and to engage in audiences. And that's sort of what I've been doing. So all these little trends that happen on TikTok, I've rediscovered that, it is fun to dance, and in midlife, maybe it's a crisis, but it's been really fun to be able to do that because I can't stay past 9 o'clock to go clubbing anymore.
Well, I believe you have a teenager or two tweens, and I'm wondering what they think of dad's TikTok use. I know my teens and tween would be horrified, but then again, I don't have the dance moves that you do.
Well, so I actually joined the same time as my youngest tween. So my twins are 12. We joined the same time, so we follow each other, and it's just really nice. My 17-year-old doesn't know about it, so there's that. And even if she did, I think it would just embarrass her to no end. So we don't talk about
Yeah.
it.
Well, I think people definitely need to check it out. And that if people don't have TikTok like I do not, at least they can follow you on Twitter where you post all of them there. So like you said, it's a kind of a multi-platform way to get across messages and dance. You're also,
Well, I mean, I think that's it, right?
yeah,
I'm always trying to use it as look. It's not a look how well I do this. It's more like look so you can learn something.
right. It's always got a public health component in addition to the dance
Right.
component. So you're also quite the well-dressed oncologist, but you're now wearing scrubs these days instead of your suits and using the hashtag scrubs over
Right.
suits. So can you tell us a little bit more about that?
Yeah, so it was when we started learning that we were going to change normal operating procedures at the cancer center. It actually dawned on some of us that perhaps we shouldn't be dressing the way we're doing. I had long abandoned, for example, long ties during clinic because I do think they're a nidus for infections. So in clinic, I've been wearing bow ties as my preferred, neck neckwear. So then this occurred, and I was just really concerned about bringing stuff home. I didn't want to expose my family any more than I could, and I was looking for ways to control the risk. And there was a lot of debates about whether or not wearing scrubs is actually effective to mitigate infection risk. And I think that's true. I don't think we'll ever know for sure because who's to say that I would have gotten infected in the market, worn scrubs the next day, got sick 2 days from now. Was it the market or the fact that I was in clinic? So there's no way to know. But in terms of looking at this in the context of things I can control, that's where this came from. I wanted to try to control something for myself. And so that's why I put away my suits. And in any clinical encounter, I wear normal clothes. I change when I get to my office. I go from my office to clinic. Then when I'm done, I come back into my office. I put the scrubs into a little paper bag. I put on my regular clothes and I go home, and then I can put the scrubs in the washing room, and that's where this comes from. And that's sort of been my new habit, but I do miss my suits.
Yeah. And I think you're right. Like there's so much we can't control that when we do the small things that we can, then I think that gives us a little bit of comfort in a time when there's so much that's out of our control. So
Yes, exactly. Exactly.
how do you have time for everything you do? Taking care of patients, conducting research, writing, dancing, social media. Do you sleep?
I think there was just something on NPR this morning about new insomnia in COVID-19. And I think that's definitely true. I tended to wake up, I would wake up at like 5:30 in the morning most days, but it would be, you spend a couple of minutes just sort of tossing and turning, and maybe I'll check my phone to see what I missed by emails. And then I get up, and usually it's about 15 minutes of just lingering. That's changed since all of this has happened. I'm usually in a sound sleep, and I will bolt awake at 5 a.m. and it's been the same. And my process now is I do check my email, and I check Twitter to see what's happening, and it's that part is new for me, where it's more of this. I need to find out what's happening. I need to find out what's going on with colleagues who I know are also up at that time. It's just a way I find I'm very connected with folks on Twitter, and I just need to know they're okay. But my daily thing is, I create a little list. I kind of talked about that a little bit, but I come up with the 5 things that I need to get done that day, and I do them. And that's always how I've operated, and I think that's probably how I can do what I do. But I'm more cognizant now of things that I'm thankful for. And I just did a TikTok about the weekends for me mean so much more because I can actually be with my family. And I just think being in the hospital, I don't have the luxury of staying at home. And I know a lot of people don't see that as a luxury at all. So I'm not minimizing in the bed, but it would have been nice to have the choice.
Right. Are there gaps in cancer care that we as advocates should address? And what can patient advocates do during this pandemic to advocate for the best care for cancer patients and survivors?
Well, I think it's, people need an ear, especially now. And I think where the advocates have been the most useful is directing attention, on the individual level where, someone is facing a new breast cancer diagnosis. I've had advocates say, this is your next step. These are the questions you need to ask. You should ask for a second opinion. You should do, just giving really practical advice. And if there's anything that I think you can do at this time, it's to give that practical advice. And someone told me this about my own tweets early on in this, is not to go down that rabbit hole of bad news and fear. Yes, the story about, how many people are dying in Italy, the fact that they're running out of coffins in Guayaquil, Ecuador, those are all so horrific. And it's absolutely important to understand what's going on with this infection. But just remember that as an advocate, and I consider myself an advocate as well, people are looking to you for something to say. And it may not be just to see what you think is so horrifying about this whole thing, but they're looking for ways to move forward. And I think we all have the responsibility, whether that's, helping provide meals to everybody who lost their jobs, or showing up to work as an essential employee, or telling people, yeah, you still can get a second opinion. I mean, people are looking just for that guidance because I think, like it or not, there is a lot of fear right now.
And I think you're right about, I mean, social media sort of can be this double-edged sword. We have the community there. There's a lot of really helpful information, but there you can definitely overload on it. And there's a lot of bad news out there. So you got to find that balance and kind of put up those boundaries for yourself to make sure that use it in a way that's helpful, but not that just kind of compounds the fear that you're already feeling. So
Yeah, that's exactly
so
correct.
I like to ask this, and this is my last question to you. I like to ask this question of all of our podcast guests. What do you see as the silver linings in the situation, both for you personally and also for the cancer care system and how we deliver care to patients and survivors?
I've given that a bit of thought about what is the silver lining here. I think the silver lining is that we finally are in the point of understanding that not all communities exist in the physical realm. That now in this era of Zoom, communities are virtual and they are every bit as important as anything else. That even though one is stuck in their home or stuck in another town or in another country altogether, or whatever the circumstance is, that you can always find community and that community can sustain you. So I think that's the silver lining for folks, especially those who are not on social media, to understand that there's never, if you need help, there is a virtual hand out there that can do that for you. I think for the cancer community, we're learning very quickly that we need to adapt to the real world way people are asking to have their care received. So it's saying that, there's no real rationale for mandating that every visit be happen physically. We now know that there's a rationale for telehealth. We now know there's a way for us to expedite drug approvals to meet the needs. And there's a way to conduct clinical trials. And there's absolutely a system in place for rapid collaborations to occur. So hopefully COVID-19 has made that very, very frankly obvious, and we can expedite clinical progress.
Wow, thank you. I think those are incredible silver linings, and it's a great reminder. There are things that are going to be positive that come out of this and that we're learning from this experience. Thank you very much, Dr. Dizon, both for all that you do for cancer patients, for your advocacy, your writing, your education, and also for your time today to share your wisdom and insights. You can find Dr. Dizon on
Yeah.
Twitter and TikTok at drdonsdizon. And if you're like me and haven't joined TikTok yet, he posts his TikToks on Twitter, so you can see them there. And check out the show notes for a link to his Medscape diary. Thank you, Dr. Dizon. We really appreciate you.
Oh, thank you, Shelley. Thanks for the invitation.
Great. We really appreciate you. Bye. Thank you.
In our next podcast, we look forward to talking to Jamie Ledesma, an attorney who specializes in cancer rights. Jamie will help us understand how health policy is changing at a rapid pace at both the state and federal levels. As a cancer survivor herself, Jamie will also share what it's like to be a patient navigating the healthcare system during this difficult time, and she'll give advice to fellow patients who are looking for answers. Thank you for listening to Cancer Convos. For more information about cancer survivorship and to find helpful resources, visit NCCS online at canceradvocacy.org.